So she's really laid out a challenge I can't disappoint. So I have to tell you that I got up this morning at 3 a.m. And I was thinking about Wendy in not so favorable terms as I hauled myself out of bed. I got on the train and tried to sleep unsuccessfully, worried about my kids. I've got teenage, early 20-year-old kids. And then I came here and I listened to a truly phenomenal talk about STDs. Now I'm really worried about my kids. And as I was sitting there listening to the presentation, there were two things that struck me. One was, I wish I had a photographic memory. And the second was, as soon as I get home, I'm going to get hold of those 4 kids. And I'm going to bombard them with every statistic to try and get some measure of the concept of abstinence. Not sure I'm going to get too far, but it's worth a try. So we're going to move on to something a little bit more mundane here, and we're going to talk about the management of hypertension and dyslipidemia, management of hypertension and cardiovascular disease. And I think one of the things that you all know is the data on this slide. You see it on the front of lay publications, it's in every patient care magazine, it's just all over the place. And you know, we strive very hard to improve outcomes, and as this slide would suggest, we are making some progress. In fact, we're making pretty phenomenal progress. But there is still absolutely an opportunity for change. And if we think of the 3 cardinal risk factors for premature death in women, they are hypertension, dyslipidemia, and diabetes. And we know that each of these diagnoses presents to us a therapeutic opportunity. And in each encounter with every patient that we see in clinic, no matter what type of specialist we are, we have a golden opportunity to impact change. And for hypertension, as we all know, this is a silent disorder. So the challenge is really there before us. We've got to work hard to try and be proactive about identifying it and then persuading our patients to take a medication for something that they don't feel. And the only way to make the diagnosis is based on physical examination. And the definition of hypertension is after 3 consecutive readings taken with the patient sitting in a comfortable position, arm resting at the level of the heart with a mean being above 140 over 90 millimeters of mercury. So we know that the control rates, even though they've improved ever so slightly, they're still abysmal. We know that the prevalence being over 55 million makes it one of the most common diagnoses made every day in the US. However, we also know that the control rate is far beneath where it should actually be. And if there's one thing that's shifting our thought process with respect to hypertension, is the fact that we now have an aging population. We are doing a phenomenal job of keeping people alive longer. Now, although people are living to be much older, the average life expectancy for a woman in the US today is 82 years of age. They are living with comorbidity. And the comorbidity in and of its own right presents multiple problems, one of which is polypharmacy. And if we look at the trends in hypertension over the last decade, the one thing we know about hypertension when we evaluate it in the community setting is that systolic elevations of blood pressure are way more prevalent than the old traditional essential hypertension with both the systolic and the diastolic elevated. Now that has multiple implications in terms of therapy. But it also harkens back to the traditional education model for hypertension, which was initiated approximately 50 years ago. And that was that systolic elevations in blood pressure was a physiological representation of the need to increase cerebral perfusion. Well, that's hogwash. Because what happens with people who've got isolated elevations in their systolic blood pressure is that they have strokes. So we have this increased recognition not to ignore the patient who comes in the door with a diastolic of 70, but their systolic is 170 or 1. That's learning point number one. Ignore isolated systolic hypertension at your peril and recognize that it is the most prevalent form of hypertension in the US today. If we look at what are very significant prognostic indicators of adverse outcome in women with hypertension, well, we don't have to look too much further beyond weight gain. And we know it is the scourge of increasing age. We know that, in fact, the impact of increasing weight has a much worse prognostic, it is a much worse prognostic indicator in younger women than it is in older women. So for those women who come to clinic who are in their mid-30s to mid-40s, where we really want to initiate aggressive preventive management strategies, if there's one thing that we could focus on, is weight control at that very early age, because this is where we see the greatest increase in systolic and diastolic blood pressures is in that 35 to 45-year-old age group. And then there's our lovely friend, the menopause. Now, we could talk for a very long time about what the impact of menopause is on hypertension. And there's a lot of controversy surrounding this particular discussion. One thing that we do know is that hypertension, or blood pressure I should say, increases on average by 4 millimeters of mercury in the 3-year perimenopausal period. So you might say to yourself, 4 millimeters, well, that's nothing. Well, let me remind you that every 2 millimeters increase in systolic blood pressure is a 7% increase in MI risk and is a 10% increase in stroke risk. So when we start to look at those unbelievable outcome statistics, where women jump from being relatively protected from cardiovascular disease to exceeding our wonderful male counterparts, it happens in a very short period of time. And a lot of that acute increase in cardiovascular risk exposure can be attributed back to this very dramatic change in blood pressure. So learning point number 2, in those perimenopausal women, watch blood pressure changes like a hawk. Be proactive in instituting therapeutic lifestyle change. It absolutely does not mean that you need to write another prescription. These are increments in blood pressure that can be managed if we can get our patients' attention without drug therapy. Why does it happen? Well, there are several proposed physiological mechanisms accountable for this increase in blood pressure. One is salt sensitivity. So there's in the kidney, which is regulated by estrogen. And we know that as circulating estrogen levels decrease throughout the perimenopausal period, the reabsorption of salt at the level of the distal convoluted tubule actually increases. So in response to salt loading, which many of us do by some of the foods that we eat, we actually are exacerbating an underlying predisposition to this over-enthusiastic salt channel in this perimenopausal period. The second actually relates directly back to vasomotor activity. And a lot of time has been spent discussing the relative contribution at a cellular level of estrogen to vasodilation. And I can summarize it in one sentence. Estrogen is a vasodilator. And as estrogen levels start to decrease in that perimenopausal period, the ability for estrogen to regulate nitric oxide production, overall endothelial cell vasoreactivity is impaired. So we know that blood pressure increases, we know that salt sensitivity is a contributing problem, and we know that that salt sensitivity can then be traced back to levels of estrogen itself. So when we go back and we say that learning point number 2 is focus on therapeutic lifestyle change in that perimenopausal period, really getting the attention of a female who has a great likelihood of presenting themselves for clinical care, salt restriction is a great piece of advice to give a patient at that time. Now here's the bad news. The bad news is that we use this cut point of 140/90. The reality is the risk associated with blood pressure actually starts at a blood pressure of about 110/70. So that's somewhat depressing. And we don't share that information with our patients because I think they'd feel they were on a slippery slope to nowhere. So what we recognize from this is the risk starts very early on at fairly low levels of blood pressure. And it is the ethos of prevention that provides us with the opportunity to educate, 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 and educate. So what we're trying to do is prevent this inexorable progression. Now, just as a refresher, I'm fairly confident everybody knows this already, the definition of normal blood pressure is a systolic of less than 120 and a diastolic of 80. Please pay close attention to the word "and." It is necessary for both numbers to be under these two values. Pre-hypertension was a diagnosis category that was introduced approximately a decade ago. Nobody's too sure why it was introduced because right now it doesn't have a therapeutic implication. But what maybe it does do is increase our focus on therapeutic lifestyle change. It's like a hallmark of bad things to come. And it gets the attention of the patient. It doesn't have an ICD-9 code, so it's a little bit difficult to know what to do with it. Most of us are liberal in our interpretation of that. And then stage 1 hypertension is a systolic of 140/159 or a diastolic of 90/99, and then stage 2 is above that. So we've got 2 stages, a pre-hypertension and a normal category. So when I come to manage a patient with hypertension, I say to myself, I have to have very clear goals of what I want to achieve. Well, obviously, number 1 is I want to control the blood pressure. But what does that mean? Basically, blood pressure is just purely a surrogate marker. In and of its own right, it doesn't mean an awful lot. But it's like a window to the soul parameter, a little bit like LDL cholesterol or HbA1c. We use it in clinic. And we have patients, by understanding what it is, to understand the direction in which the patient might be heading. So our first goal is to control the surrogate marker so we have a sense in this partnership with our patient that we're on the right track. But really, the other things that we are trying to do is to protect the heart, protect the kidneys, and ultimately protect the vasculature throughout the body. And we differentiate these because different classes of drugs have differential potency in their ability to protect the heart versus protect the kidneys, etc. And then recognizing that this is a silent disorder. We don't want to make our patients feel sick. This has probably been one of the biggest challenges in antihypertensive therapy, is preserving quality of life, which means trying to avoid poverty, trying to avoid side effects, and make things tenable with the rest of what's happening in his or her world. And then as our aged population continues to expand, we need to recognize that our therapies don't interfere with concurrent therapies for other diseases. And that can be an inexorable challenge that presents us all the time. How low do we go? Well, you know, unlike the story with LDL cholesterol and HbA1c, we really haven't seen a huge amount of controversy here. For uncomplicated hypertension, the number's 140/90. Since the last time I presented at this conference, there was 2 studies actually published which showed there was no benefit to lowering blood pressure more aggressively in an uncomplicated patient population. In patients who've got high risk of coronary artery disease, so this includes patients with chronic kidney disease, diabetic patients, patients with known vascular disease, we target a lower blood pressure of 130/80. So that's learning point number 3. 140/90 for the general population, 130/80 for the rest. And I say to my trainees all the time, show me an uncomplicated hypertension and I'll give you a Smartie, because I don't very many of them, but I'm sure they exist somewhere. Therapeutic lifestyle change. Maintenance of weight for sure. How does weight contribute to high blood pressure? Well, the greater percentage of adipose tissue in the body correlates directly with an increase in sympathetic nervous system activation. And this has always been the assumed connection as to why do people, as they gain weight, become hypertensive. So it's an autonomic nervous system derived pathophysiological mechanism. Increase in physical activity. They don't have to join a gym, they don't have to wear crazy workout gear, they don't have to feel uncomfortable. Walking, anything that is above what they currently do. I use the AHA STEP program where I encourage my patients to use a pedometer, which we give out to our patients in clinic, and ask them to increase the number of steps per week by 10% for the first 10 weeks. By the time they've got to 10 weeks, they're now easily up to 30 minutes of vigorous exercise a day. And I do say to them 7 days a week because I know how psychology works. If you say to somebody 5 days a week, yeah, I won't do it today, I promise I'll do it tomorrow, and then tomorrow comes, nah, I'm going to do it the next day, and before you know where you are, you've done it twice a week. And I am guilty of that one myself. Moderate consumption of alcohol. As an Irish woman, it galls me to say this. Just kidding. So the recommendation is 1.5 units a day. That's about 10 ounces of wine. Just make sure it's a good one. Limited salt intake, limit saturated fat intake, and cholesterol in the same vein. Adequate intake of potassium, calcium, magnesium. This usually centers around intake of dairy. And then avoid tobacco, recognizing that tobacco is an acute vasoconstrictive substance, but in the long term contributes to arteriosclerosis and atherosclerosis. Does this approach work? Absolutely. Are people compliant? No. And you know, the interesting thing about it is that it's actually not an unpalatable approach to life. It's actually kind of nice if you do it. In terms of its potency, it's equivalent to 12.5 milligrams of hydrochlorothiazide, head-to-head comparison. The problem is for some patients, it can be more expensive than a less healthy diet might be, and the exercise, they just can't find the time, although I've never, ever accepted that as an excuse. So we know that this works, and it would just be wonderful if adherence was a little bit better. So let's say it doesn't work. Well, then we have a range of different classes of antihypertensive meds that we can use. Learning point number 3. Monotherapy rarely cuts it. And I'm going to show you why in a moment. But if you look at the average responder rates for different classes of drugs, a CCB, beta blocker, central alpha antagonist, thiazide diuretic, ACE inhibitor, and a peripheral alpha antagonist, average response rate about 50%. So the benefits of combination therapy are actually quite broad and varied. One is use 2 drugs, increase your efficacy. Decrease toxicity. This could be very attractive given that lack of compliance is attributed to cost and side effects for most patients. Reduce cost to patients in terms of copays. Well, only if you're using fixed dose combinations, and they're generic fixed dose combinations, which are somewhat limited on the US market today. And then is this concept of target organ protection, going back to what I said before. Yes, we want to control blood pressure, but we also want to select classes of drugs that might have added protection for the heart, such as ACE inhibitors or angiotensin receptor blockers, and the kidney. So we have to think of the potential advantages of using two medications, two different classes of antihypertensive drugs. So when might you know de facto that you should do this? Well, it's a very easy rule of thumb, learning point number 4. If the patient has a blood pressure that is 20 millimeters of systolic away from target goal or 10 millimeters diastolic, and please note I said or, either of those two situations, our current antihypertensive meds are not potent enough to achieve this as monotherapy, just based on simple pharmacology. So this is the current recommendation that has been in existence for 9 years. If a patient comes in the door, you are ultimately going to need 2 medications to get that patient to go. Now, whether you to start 2 at once, that generally is personal preference, or whether you want to wait and get there, it's kind of up to you. Efficacy and long-term maintenance of successful blood pressure control is associated with early initiation of combination therapy. So I would leave that out there for you to consider. So where do you use what medications when? So for prehypertension, as I said before, lifestyle only. I will tell you that there is a very large NIH-sponsored study on using drug therapy in the prehypertension phase called the SPRINT trial, which got underway a 1.5 years ago and will take about 7 years to complete. Stage 1 hypertension. Now, this is the thiazide dogma. No matter where you go, based on a study which in my mind was inherently flawed, called the ALL-HAT trial, it is currently recommended that everybody be treated with a thiazide diuretic as part of their regimen. I think this concept of one size fits all misses the point that no 2 patients are alike. And especially for women and older women where incontinence may be a serious adverse component of their daily lives, considering making that worse is just purely inhumane. So this simple concept of thiazide diuretics for all, even though it's what's in the guidelines, I'd like to be cantankerous and say, maybe not so much. The alternatives are an ACE inhibitor, an angiotensin receptor blocker, a beta blocker, even though there's been an increasing degree of controversy there. Calcium channel blockers, both dihydropyridines such as amlodipine, or non-dihydropyridines such as verapamil, or any combination of those if one drug doesn't get that patient to target goal. And then for stage 2 hypertension, any combination thereof. So I'm going to bring you back to your pathophysiology class ever so quickly. And I loved this lecture. This slide is actually from my 2nd year medical school pharmacology lecture. And the man who gave that lecture died last year, and I brought this slide back to the funeral. I went to medical school in Ireland, and gave it to his wife. And she started to cry when I gave her the lecture, and she said, "Do you know how many students have brought this slide back to me?" I thought I was incredibly original. So, why am I showing you this slide? Well, the reason I am is because each class of antihypertensive drug targets one component of this equation. So we know that blood pressure is the product of cardiac output and systemic vascular resistance. It's just like a capacitance system. You have the heart, that's the pump, the kidney, that's the release valve, and then just all the vessels, that is the circulation. So we use beta blockers to reduce heart rate, we use calcium channel blockers, alpha blockers, diuretics to a certain extent to reduce peripheral vascular resistance, ACE inhibitors, angiotensin receptor blockers, beta blockers, direct renin inhibitors to reduce renovascular resistance, diuretics to reduce stroke volume. So we've got all of these classes of antihypertensive drugs which target different components of this system. How do you know what to use with what? So the green bars here are the combinations that have been shown to be very effective. So diuretics and a RAS blocker, diuretics and a beta blockers and calcium channel antagonists, RAS blocker, channel antagonists. And to be honest with you, they are the most common combinations that are used in clinical practice because they work. And not only do they work, they're reasonably tolerable. I think given everything that we know about the relationship between estrogen and hypertension, it is reasonably easy to understand why we use ACE inhibitors and angiotensin receptor blockers so commonly in women. Not only are they highly tolerable classes of drugs, particularly angiotensin receptor blockers, but they target on that vasomotor activity piece. And as a result, we see a huge uptake of ACE inhibitors and angiotensin receptor blockers when treating women with hypertension. This is directly from the JNC7 guidelines, which give you the indications for when you use each of the individual classes of drugs. I think this is a useful slide for you to refer back to, but please don't take it as dogma. There are always exceptions to each of these individual classes. I think the contraindication section is real. The reason why heart failure appears in both places is beta blockers are contraindicated in decompensated heart failure, whereas they may have a heart preserving element, so to speak, in patients who have preserved cardiac function. So I want to do two very quick cases before Wendy hauls me off the stage here. So the first one is a 55-year-old African-American female with a history of hypertension for a decade that we know about. Cardiovascular risk factors include she's diabetic, she is obese, and she has a long-standing history of fibromyalgia. Her meds, in addition to her oral hypoglycemic meds, include simvastatin 40 milligrams for the management of her dyslipidemia. Her family history is notable in that her father developed chronic kidney disease at the age of 50, and he died at 67 of a myocardial infarction. Her mother died in childbirth with her only other sibling who also died. So she has no other siblings and no other known relatives that she can look to for further extrapolation of her family history. Her blood pressure showed stage 1 hypertension with a systolic of 150 and a diastolic of 92. She had a heart rate of 74 beats per minute. Her BMI was 28.9, which I should correct myself and say she's overweight, not obese. And her waist circumference was 37 inches. Cardiovascular exam was normal. Her EKG showed LVH by voltage criteria. Learning point number 5. Don't underestimate the value of an EKG done in the clinic to determine the impact of hypertension on cardiac function. If your patient has LVH, you know that the hypertension has been long-standing no matter what the patient is able to tell you. She has impaired renal function with an eGFR of 48. Her glucose and her HbA1c showed that her diabetes is well controlled. She has combined dyslipidemia in that she has an elevated triglyceride level of 220 and a low HDL for a woman at 44. So the parts that I would point out in this particular case are the following. Fibromyalgia. Tread very gently if you're considering calcium channel blockers, because they can markedly aggravate fibromyalgia. Chronic kidney disease, in the setting of a family history of chronic kidney disease, think RAS inhibition. Think about the potential of ACE inhibitor, angiotensin receptor blocker, especially given that you know that she also has dyslipidemia. You could consider a thiazide diuretic. Probably African Americans of all racial subgroups respond in the most potent manner to thiazide diuretics, would be an additional option. Ideally, the combination of therapeutic lifestyle change plus one drug should get this patient to target goal. What these patients will typically say to you is, give me 3 months to try and do this without anything, and I promise you I'll do it. I'm going to get back to that concept in a second. Case number 2, 75-year-old Caucasian, 20-year history of hypertension. This lady is one of my favorite patients. She's a spitfire. 20-year history of hypertension, mild urinary incontinence, and a former smoker. She's got stage 2 hypertension. However, her heart rate is 68, her BMI is 25, her waist circumference is 30, her weight is 140 pounds, and she's a very proper lady, and she's about 5'7" tall. EKG within normal limits, despite the fact that she's had a 20-year history of hypertension, and that's telling. Her lab work was normal. She had a good HDL cholesterol, her sugar was normal, and her renal function was also normal. The take-home points from this lady is she's had a 20-year history of hypertension and she has no sign of cardiac impairment based on EKG. That is encouraging, but it does not mean that you get to ignore her hypertension. The one thing you don't do is make her angry. Don't give her a diuretic. In this case, CCB is a reasonable approach, an angiotensin receptor blocker is a reasonable approach, calcium channel blocker, just be careful of pedal edema, particularly in women who like to wear their shoes. So lots of options in this particular lady. When I said to you a patient will tell you, just give me 3 months of therapeutic lifestyle change, you're going to get caught up in the flurry of just 3 more months, doc. It was my son's communion or bar mitzvah, and then I had a wedding, and then I had a funeral, and stuff happens. I might use different terminology if I wasn't on a stage. The bottom line is be careful about these extended therapeutic lifestyle changes. Know your patients and what's achievable. But this is something that I want to leave you with, this concept of therapeutic inertia, because this is learning point number, I think I'm on 5, 6, sorry, I've given you a lot of learning points. But maybe the most important, this is from the Partners database within the Harvard system, the number of office visits where patients left without any intensification of their antihypertensive drug therapy. So patients who came in with stage 1, stage 2, accelerated hypertension, more than half in every category are leaving without an intensification of their drug therapy. And you can imagine what sorts of conversations took place in that clinic, right? Many of these are primary care, internal medicine, office visits where there's a whole plethora of other conditions being discussed. So when you think about this of therapeutic inertia. It's real and it has the potential of a huge negative impact. We did a survey within our own practice. We've got 6,200 patients, and we went back and looked at all of our blood pressure numbers and at our clinic notes. It was a very tedious study which we had some medical students work on over a summer. And what we realized is exactly what this data showed is we as providers have a much more optimistic view of how aggressive we are in medical practice than we actually were. So in many cases we go back and we look at this data and we're like, what were we thinking? How did we let this go for a period of 6 months or 9 months? And you look into the clinic notes, wedding, funeral, birth, marriage, death, everything that happens. So just be careful about that. So I'm going to leave you with a plea. Hypertension is a therapeutic opportunity. It's something that everybody in this room can positively impact in a woman's life. We can make change. It's our responsibility to start the conversation. Thank you very much. Can we put the mics on? Nope. Try again? Nope. Can you hear me now? I can repeat your question if you want to say it.
First of all.
There you go.
So, first of all, thank you for a fabulous, fabulous lecture.
My pleasure.
Question, can you please address the issue of what we use in the young woman, reproductive age, who is at risk for pregnancy?
Yep.
What do you do about ACE inhibitors and the contraindications? What do you do?
Yeah. So, you know, we treat that situation the same way as we do, how do we treat dyslipidemia in a woman of childbearing, who has of childbearing potential, of childbearing age. And that is that we don't have a requirement to change medication until we know a patient is actually pregnant. The teratogenicity data has kind of taken on a life of its own, and we know that there is no known teratogenicity if drug therapy is stopped within a week to 2 weeks of getting that positive pregnancy test response back. So I think the most important thing is we don't cut out every class of antihypertensive drug except for alpha-methyl-dopa, which is the only one that's been tested in pregnancy. So we've got calcium channel blockers, we should be using them. We've got ACE inhibitors, we should be using them. We've got angiotensin receptor blockers, we should be using them. I can honestly tell you, in women who are less than the age of 40, which generally captures that childbearing age range, not exclusively, I know, but kind of the big chunk of that age range, I use angiotensin receptor blockers a huge amount of the time.